Any final points on the progressive functional deterioration in patients with bipolar disorder, Dr. Goldberg?
So I think to myself, and I tell patients and colleagues, I think this is still a good prognosis illness, particularly if we can get to it early. This is my subjective impression.
Early intervention.
Yeah. So even though we don't have droves of 40-year follow-up studies in the same patients to answer these questions, there is a sizable percentage of patients who will show persistent impairment in functioning. And since we know certain medicines may work better early on than later on, some are maybe more robust, clozapine, even ECT actually tends to work better if you haven't had umpteen episodes go by.
Yes.
So it's better not to have a billion episodes go by. And in part that's common sense, in part it's inference from naturalistic studies. So I will say to an early episode patient, we have to be extremely vigilant about identifying anything we can think of that's going to reduce the chance of your next episode, whether that's residual symptoms and treating to remission, with depression, psychosis, addressing cognition, substance use, etc., so that we can so that we can get you to that 3 to 6 month point of wellness, so that we can then not have you have your second episode.
So can we conclude that, I guess, preventing non-adherence will help patients in terms of the progressive functional deterioration, that an intervention with adherence is going to improve not only the prevention of the next episode, but the long-term improvement in terms of functional outcome?
I think that has to be.
Are we there?
I think that has to be our till proven otherwise assumption, right? I mean, if we know with certainty this is a patient for whom non-adherence has been the issue, we may often reflexively think perhaps a long-acting injectable makes sense. But you're asking an even broader question, which is before you've become the non-adherent patient.
Exactly.
I'm going to predict that there's a high chance of non-adherence here.
Exactly. In other words, that we should assume that every bipolar patient with bipolar disorder who we see is at risk of non-adherence, therefore at risk of a progressive functional deterioration. So we should start from the very beginning to try to intervene in a preventive way.
Absolutely. That's the way I think about it. Absolutely.
It needs to be in the dialogue with the patient and the family. I mean, just in terms of forecasting.
Key point, and the family.
Yes.
Family support networks, very, very important. Yeah. Whether it's I'm thinking about the same thing, whether it's a private practice setting or community mental health setting, same parameters. We always think about preventing episodes in schizophrenia, but we don't concentrate too much on bipolar. But the same strategy holds true here, and the same complications hold true. So.
But to the point that we focus on prevention of episodes, but we should also consider functional deterioration as a key outcome that we want to prevent.
Absolutely.
I just add one thing. We often talk about residual depression as being a source of morbidity, and I don't think there's question there, but, and the notion that manias or even hypomanias are comparatively less at the time. But I'm thinking, as you're talking about patients who've become non-adherent and had a disastrous mania. It only takes one disastrous mania to destroy a career, to wipe out finances.
Marriages.
Had a patient who had an explosive rage attack, put somebody in the hospital. There were legal ramifications. It could take years to recover from the psychosocial damage that is caused by one sort of tsunami-esque mania.
Absolutely.
So side by side with all the things I'm describing about residual symptoms and adherence, just to point out, we really don't want to see a disaster come your way. And if we have a successful treatment, we don't have to. We have a way to prevent it.